Good afternoon, ladies, gentlemen, distinguished guests, and welcome to our session on a dull, but luckily at this point, not rainy day. My name's Catherine Taylor. I work at Management Sciences for Health, MSH, and I'll be your moderator for the afternoon. I would like to thank you all for coming today on behalf of MSH and also the American College of Obstetricians and Gynecologists, or ACOG as they're often referred to, and you'll hear me referring to them during the meeting like that. This is a really very nice space that they've offered to us this afternoon for this program, and you may see it in your running order, but just to remind you, after we've finished the next hour and a half, when we have a reception, there will be an opportunity to tour the museum, which is really extremely interesting. So if you do have the opportunity to stay behind, please do join in. As the program demonstrates this afternoon, we've got a very interesting but challenging topic that we want to discuss, and I'm hoping that you will really enjoy the debate. This is not an afternoon where we're going to come up with the solutions or the answers, but it's the beginning of a longer discussion which will, in knowing the maternal and newborn health community, take many decades to resolve. Before we really get started, I'd just like to make two announcements, or two things that I'd just like us to think about. One is that this is a very solemn day for many of us because it represents the 17-year anniversary of 9/11. Just like to take us back to that day for a minute, where many of those victims of 9/11, as we are today, going about their business as usual when tragedy struck. The first responders during that time we have to think about, because they were very much the heroes of the moment, working night and day to save as many lives as possible. And in thinking about that, we also have to think of the frontline workers that we're all working with shoulder to shoulder during our days and the work of our project. And these frontline workers are working tirelessly to improve maternal and newborn health and reduce death and disability. And I'd like to also, my second point is to acknowledge one of our own heroes in the maternal health global community, and that is Dr. Umbaruku. Dr. Umbaruku, many of you know, was committed to maternal and child health throughout his career. I was very privileged to be able to serve with him on the White Ribbon Alliance board for a number of years. Dr. Umbaruku Godfrey was a native of Tanzania, and as a doctor, a very young doctor, was posted to the very north, to a remote area for a number of years when he first qualified. And slowly but surely, he made a huge impact into the maternal mortality of that particular region. He took that experience and know-how with him throughout his career and would often refer to it. His particular interests in research were wide-ranging, from health system strengthening to new technologies and respectful maternal health care. So just like to remember him. He died at the weekend. Some of you may not have already heard, but he was certainly a hero in our maternal health community and will be sadly missed by many of his colleagues. So to begin our session, I just take us back a little bit to the last 15 years between 1990 and 2015, where we saw in the global health community a reduction in maternal mortality by about 44%, which is a really great progress to have made during that time, but unfortunately fell short of our target of a 75% reduction in maternal mortality. We also saw during that time, while under 5 mortality went down dramatically, the proportion of neonatal deaths in relation to under 5 mortality actually grew. So now we're in the era of the Sustainable Development Goals, but still have an unfinished agenda from the Millennium Development Goals, and even more ambitious targets in which to achieve in the next 15 years. The Lancet Global Health Commission on High Quality Health Systems released their report on September 6, just last week. This report makes a number of recommendations that are important to our work in global health. And for this next hour and a half, we'll be concentrating on focusing on one of those questions in particular, and that is place of delivery, place of birth. The Commission calls for redesigning the service delivery. The report recommends that hospital or specialised health centres provide care during delivery, and that there is access to advanced clinical expertise within those facilities, and that primary healthcare is really the facilities there would be better managing low acuity conditions. So these recommendations actually has huge implications for the design and planning of our work in the field. Over the course of the Safe Motherhood Initiative, as many of you will know, we have debated long and hard about the place of delivery. And during the last while, we've increased the number of deliveries by a skilled attendant quite dramatically. But unfortunately, we haven't seen the dramatic results that we'd hoped to see with that change, as there has been called into question the quality of the delivery services that are available, even with a skilled attendant. Sometimes we think that this is just a problem within low resource settings, but we do know now that this is a global issue, continues to be a global issue. And we're reminded of this as tomorrow here actually in DC, Mayor Muriel Bowser is actually hosting a mayoral summit on maternal mortality, when she's bringing a number of mayors together to look at this issue, and to look at, as many of you who have seen the newspapers recently have realized that we continue to have issues in this country around maternal health care and providing women who have not only a safe delivery for them and their newborns, but also have a good birth experience as well. So in the next hour and a half, we'll be looking at the recommendations of the Commission and looking at what this will mean for health systems going forward. What are the sorts of questions that we should be asking? What are the sorts of research that we should be recommending? And also how we look carefully at what the implications of these recommendations will have going forward. So we have a panel of very distinguished speakers with us. Unfortunately, Dr. Margaret Crook, who is going to talk first, couldn't be with us. But because of technology, she's going to be beamed in from Boston. So we're very excited to have her here. Margaret is, of course, the Associate Professor for Global Health at the Harvard T.H. Chan School of Public Health. She's currently the chair of the Lancet Global Health Commission. And she'll be giving us around 20 minutes talk about the results and recommendations of that commission. Then we will go on to Michelle Hino here on my left, and Michelle is a certified nurse midwife, and she's employed by the Indian Health Service. She provides care to women in a small rural hospital in the Acoma reservation for the Navajo Nation. And she'll be talking about women's experience building trust and how we can encourage women to use services. Then we will go on to Dr. Usman Fai. Dr. Usman Fai has been the project director for the Integrated Health Program in DRC for the last 8 years. And as that program winds down, he's actually going to be moving to the US. So we'll be very lucky to have him here in DC. And he'll be talking about the challenges of these recommendations for the system and for the community within DRC, which I think are applicable to many settings. And then finally, we'll have Dr. Barbara Levy from ACOG. Dr. Levy is the Vice President for Health Policy at ACOG here, with over 25 years experience with direct care research and training. She oversees the advocacy division, and she will be talking about creating a culture of safety and quality for women as they go through this experience of childbirth. So I know you want to hear the meat of the recommendations, so I'm now going to hand over to Margaret. But before that, what I just want to say is we'll go through all of the 4 presentations and then we'll take questions. And at the end of the question time, we're very lucky to have Mary Ellen Stanton, who is the Senior Maternal Health Advisor in the Global Health Bureau at USAID, and she'll provide us a summary of the discussion as we close. So I would like to now turn over to Margaret. Thank you very much.
Great. Hi, everyone. And I'm sorry I can't be with you in person, but thrilled that we could make this happen electronically. Thank you, Catherine, for that introduction and that framing. And I also want to thank you for taking the time to note the anniversary of September 11th, a day I remember very well. At that time, I was working in New York City and arrived at work to learn about what happened. I think we all feel incredibly strongly about that day and the suffering that followed. And thank you also for noting the untimely death of a hero, but also my friend and colleague, Dr. Godfrey Mbaruku. It was an honor to collaborate with him on research in Tanzania over the last decade. And in fact, I'll be sharing findings from a study that we jointly conducted over the last few years in this talk. We will all miss Godfrey as a person, but also as a role model in this community. So what I'd like to do is turn to the meat of this discussion, as you have said, and maybe we can go to the slides. First, let me just double check. Are you able to hear me well?
Beautifully, yes.
Okay, great. Excellent. So today we're here to talk about high quality health systems for maternal health, and specifically to ask the question that I think Godfrey would wholeheartedly agree with, which is, are we ready for a revolution? Because what I'm about to present to you is a series of ideas that depart from business as usual to tackle the challenge that we feel has not been tackled with current approaches. And I really look forward to a spirited debate, and I particularly appreciate your point that we may not come to all the answers here in this room today, but that we do need to begin thinking differently. And so I wanted to start by framing the problem. And that is, of course, a problem that we've observed in the work of the Commission, that coverage does not equal survival. What I'm showing you here is the red line, which is the maternal mortality target in the Sustainable Development Goals. And that, of course, is a very ambitious 70 deaths for 100,000 live births. And now what I'm going to show you is how countries are doing on this target. What you see is 3 groups of countries. Low-income countries are on the left, low-middle income are in the middle, and upper-middle income are on the right. And the reason we selected the countries for this slide is that all the countries on this list have actually met 80 to 90%, so near universal coverage of facility delivery among their women. So you can see some countries have done a great job in reducing mortality with facility delivery. Others are, maybe within reach, and yet others are nowhere near and not even close. What unites all these countries, once again, is that they've achieved near universal coverage with facility delivery, and yet what remains are stark differences in survival for women. We also know that biological factors, so one of the questions that gets asked as well, is it about the quality of care in those facilities, or is it about other things? Perhaps there are other issues So one thing we looked at in the commission is maybe there are different distributions of risk factors for maternal death. We all know anemia is a major risk factor. So here we looked at countries' distribution of women with anemia, with low levels of anemia, moderate and high. And again, we see extremely different mortality rates. So while anemia is clearly a contributing factor, there's no question that anemia does not explain the differences in mortality. So it's not just this one observation alone. I think what we're seeing is in the move from the Millennium Development Goals to the Sustainable Development Goals, we have moved from one set of targets to a much more demanding set of targets in terms of numbers and achievement that's required, but also just much broader set of priorities. And so what does this mean for health systems? Well, one is that there are more and more complex health needs that we are all tackling as a globe. But the second thing that I think the epidemiologists in the room will certainly appreciate is that we have saved the lives that were easy to save, right? The residual mortality, the remaining deaths are by definition going to be more challenging. They're going to require greater effort on the part of the health system. And so that leads us to this equation, which any of you who have followed our work have seen before more than once, which is that the basic value proposition of the Commission on High Quality Health Systems, and really of health systems in general, is this: that efforts to expand utilization, and apologies for the sirens, I'm on the medical campus of Harvard, so plenty of accompaniment here. But that efforts to expand utilization of health services by themselves cannot lead to better health if quality is not part of the equation. So simply using clinics, buildings is not the determinant of health. It's the utilization times the quality that brings us to health. And so the Lancet Global Health Commission on High Quality Health Systems, which I've had the honor of chairing together with Dr. Mohamed Pate, took on really three tasks. One was to define and describe the state of health system quality in low and middle income countries. Another was to think about quality measurement. What do we mean when we say quality, which I think has actually been a pretty difficult problem in the community. And lastly, to rethink improvement. And that's what we're going to focus on in our discussion today. I just want to introduce you briefly to the 30 commissioners from 18 countries. This is a mix of policymakers, academics, advocates, and so on. And it's been an incredible privilege really to work with them. We've had incredibly spirited discussions. And the reason for this mix, this diverse mix, is because we wanted rigorous work, but we wanted that work to be road tested. We wanted it to be policy vetted. And so we needed those debates to happen in the commission meetings and on email and in the working groups. So it's a wonderful group and of course supported by an amazing secretariat here at Harvard of a research team. And so that all work, really the 2 years of work in the commission resulted in this paper that we published last week, which was the Lancet Global Health Commission publication and Lancet Global Health, which was accompanied by papers from national commissions that accompanied the global work, editorial from the Director General of the WHO, an endorsement by 19 organizations and so on. Essentially an endorsement of the idea that we can't ignore quality any longer. And so what I want to share with you very briefly before we get to the specific topic of maternal survival is some of the key propositions of the commission. One is this one, which is that it's time to redefine what we mean by quality. And we approach quality as a health system construct. So health systems are for people. That's our first and starting point. And a high quality health system optimizes health by doing three things. By delivering care that improves or maintains health, not Monday and Tuesday and Wednesday, but every day, consistently, by being valued and trusted by all people. And that is a key function, a key measure of good quality health systems, and by being able to respond when needs change. And this is another feature that systems, I think, have failed us on over time. So we propose in the commission the following framework for measuring high quality health systems, a framework that really emphasizes the top part, the processes of care and the quality impacts, and de-emphasizes, frankly, the measurement of populations and governance and platforms and workforce and tools. Now, why do I say de-emphasize? Obviously, those things are critical. They're critical for the formation of high-quality health systems, which is why we're calling them foundations. But what we have noted in the Commission very definitely is that measures of those things, measures of doctors, measures of midwives, measures of stethoscopes or medicines, do not themselves create quality. What we want to be measuring when we're measuring quality is competent care, competent systems, people's experience, and then, of course, the impacts on health, on their confidence, and on their economic status. And so I'm not even going to read through all of these key Commission findings. You're very welcome, of course, to look at the report and let us know what you think, except for maybe 2 points. One is that we have a huge missed opportunity in our hands today. We did an analysis as part of the Commission that found that every year we are losing probably 8.6 million lives that could have been saved with access to high quality health systems. Now, of that 8.6 million, actually 5 million were among people who were already using the system. And that includes moms and newborns in those countries with high skilled delivery rates. So these are lives among healthcare users. And the other 3.6 million were among people who don't get access. So access is not solved by any means, but already today, quality is the bigger constraint toward better survival. And then the fifth point, which I want to raise here, is that improving quality of care is going to require a brand new way of thinking, and in particular, thinking at the system level. Okay. Yes, sorry, I think my slides got behind my talk. So here's the key Commission findings. So an important finding is that health providers in clinics, this is really what set us off. Some of the very early work in the Commission was when we stopped looking at tools and started looking at what happens in clinics to people who go to clinic. These data here are from 18 countries in which observers stood in the corner of the room and watched what happened in a clinical visit. And these data are available for the following services that you can see here: family planning, sick child care, antenatal care, and a couple of data points on delivery care. And why these? Well, that's what we've been measuring, right? These are traditional sort of MCH conditions, very helpful though for this discussion for sure. But it also allows us to see what gets done, what's the content of care that people get. And generally speaking, we're seeing that about 40 to 50 to maybe 60% of the items that should be done in a typical visit are done. Basic things are not done. For example, the taking of a blood pressure or the giving of a diagnosis. And so when we see this sort of a situation where fewer than half the recommended items are done, many clinicians, in fact, about half the clinicians can't properly diagnose pneumonia or TB, common conditions in their settings, is when we conclude that actually the way forward in improvement is to expand the solution space beyond one clinic and one provider at a time, which has definitely been our focus. Now, the reason this has been our focus is reasonable enough, which is that that's where the poor care manifests, right? We see poor care and we want to do something about it. So what we have spent a lot of time doing in the global community and within countries is what we call in the Commission point of care interventions or micro level interventions. These are things like checklists. They are things like short training, 1 or 2 week trainings. They are things like supervision or job aids or apps. Every day or every week, certainly I am approached by someone with a wonderful idea that's going to transform healthcare, with this phone. And that's where we've been focusing. Whereas the Commission is asking us to focus at the structural macro level, system level changes that will definitely be slower to implement, but also have a much larger potential for change. And let me just hone in on something that I'm sure you're very well familiar with, just to illustrate this point. So the Better Birth Trial was really an incredibly ambitious study led by colleagues actually just down the street from me, Ariadne Labs, Catherine Semrau and her team. And it really was just an incredible learning experience around these issues of where do we direct improvement. So just for those of you who may not be as familiar with this is a trial that worked to improve care processes, essentially using the current system of care. So what you see here is, what you see in this slide is the logic model of that effort. This is an effort in India and Uttar Pradesh, which was a massive, massive trial involving 160,000 women and 120 facilities. And this effort was really focused on the things in the middle there: coaching, measurement, and data feedback. In fact, quite intensive coaching twice a week at the early stages of the trial of the attendants, of the nurses and doctors who were in the clinics. Now, what are these clinics? Well, all of them were below the level of a hospital. About 1/3 were primary health centers, about 2/3 were community health centers. They had large delivery volumes, average delivery volumes of over 1,000 births, about 4 staff per clinic. And I want to just point your attention to one fact, which we'll come back to. The C-section rate at the end of this study was less than 2% in both intervention and control clinics. So they were working with the system as it was. They were doing their very best to improve. And in fact, there was some sign of improvement. In particular, there was a large increase in checklist adherence to 18 essential birth practices. Over time, this did decline, but still stayed significantly different. But what was most notable about this trial is there was no change in the composite outcome, which was a composite of perinatal death, maternal death, and severe maternal complications within 7 days of delivery. I assure you, this study was well-powered and incredibly well implemented to be able to find such an outcome and such an impact. And yet it found no impact at all, and in none of the sub-analyses either. And so it's this sort of an experience that, and this trial came out actually midway through the commission as we were already moving in this direction. And really the failures of many efforts, or the short-term effects, but lack of scale of many efforts that we also investigated in the commission, that led us to this set of recommendations. That really, to improve systems as a whole, we are urging countries to consider for universal actions. And beyond these, of course, there will be many, many approaches that make sense in the local context, and even these approaches have to be localized and contextualized. But in every country, we think that countries could examine how they govern for quality. Who's responsible, actually, for these maternal deaths? Whose job is on the line? Where's the accountability chain? Governing for quality does not mean having a quality directorate, an underfunded quality directorate with 1 or 2 people in a side part of the ministry, but rather making it central to the mission of the ministry. Second is redesigning service delivery, which we are going to talk about in a moment, which is about reorganizing services to maximize health outcomes and not maximize other things. Third recommendation was transforming the health workforce. We found such abject problems in performance of the health workforce that we think it's really time to rethink how we train providers. And that, we have some of the same issues in our country, thinking about our people really trained in person-centered care and community-based care. I think there's some questions that arise in our work about problem solving, differential diagnosis, certainly communication, and other items as well. And last is an issue that I think is also central and provocative, which is that we have not sufficiently worked to ignite demand for quality among the population. And they could be a huge ally in this work. So we won't have time to talk about that one today, but it's certainly one of our, I think, most provocative pieces as well. Okay, so let's go right to quality-centered service delivery redesign. And what do I mean by that? So we hold that health services have traditionally, in many, particularly the lowest income countries, but I think many countries can trace their path through this story that I'm about to tell, which were that health services, when they were expanded first, were really expanded with the notion of promoting access, right? They were seen as an important expression of government commitment, and clinics were opened in many, many settings, with the result that actually we have really quite excellent access to the first point of care in many countries, including the poorest countries. So that's what they were organized to deliver, which is to deliver access. Second, many health systems were designed to provide basic episodic care, but have not really adapted to the current disease burden and what people want of them. My favorite example, and I've worked for many years in Tanzania and Ethiopia and countries in the region, is that still health records are often visit-based, right, and not patient-based. So actually tracking antenatal care, for example, for someone over time is a real problem in many countries. Third challenge is that hospitals are overcrowded with stable patients, and lastly, that primary care facilities end up facing cases that are far outside of their scope or expertise. So this is sort of where we got to today. And so we have this graphic, which shows what we mean by a service delivery redesign. It's essentially a way to think about a health service unit. This is a district or a region, and reorganize where services are provided and by whom and how, right? In a way that maximizes the potential of a good outcome for everyone. So for example, conditions that demand advanced clinical expertise, and I would put to you that birth is one of those. It doesn't demand that advanced expertise for every birth, but it does for the complicated ones. And the trouble is we don't know which ones those are going to be. So those conditions do need to go to a place where such care, advanced care, can be provided immediately. Second type of conditions are low acuity conditions that require coordination, continuity, and really a strong link to the community. And they can move and should move down to the first level. And one example that came up in the commission, for example, is TB. Active case finding and case detection of TB is often situated at hospitals. But actually, to pick up the cases that are out there, you need to be in the community and doing that. Okay, so let me give you a little bit of the rationale for maternal child health specifically, and specifically obstetric care. So what I'm showing you is an exhibit from a paper that we wrote at the very outset of the commission in 2016 with a number of colleagues, including, you'll see Godfrey Mbaruku's name on there. And this used data from 5 countries in sub-Saharan Africa: Kenya, Rwanda, Uganda, Namibia, and Tanzania. And the initial question that we asked for this paper was kind of the question that's asked in the US.
Margaret, sorry
Yes.
to interrupt. We can't see that slide. If you could
Okay, sorry about that. Yes.
Sorry about that.
Actually, yeah. Sorry, I'm actually toggling a couple of different things, but we're there. Okay. Do you see it now?
Yeah. Yes.
Okay. So data from 5 countries in sub-Saharan Africa are represented here. Every dot is a facility. And what we did is we started with a question that's asked again in health services research in the US and everywhere, which is volume, right? Facility volume associated with better care. On the y-axis is a simple, quite basic index, 12-point index of obstetric care functions, which I'll describe to you in a moment. On the x-axis is delivery volume. So when we first ran these data, I thought, oh, okay, there is some association. Bigger, facilities with more births seem to have better performance on this index. But then I asked one of our analysts to actually color code the facilities that are primary care facilities and secondary care. Secondary care are red. I think as you can readily see that really at any level of volume, the secondary care facilities in these African countries are performing at a much higher level of this basic index. So what is this index? These are some of the items in it, so I won't go through this list. But just to say, look at the differences between the blue and the red, the primary care and the secondary care facilities. Look at the availability of skilled staff in those primary care versus secondary care. Look at the experience with emergencies toward the bottom of that bar chart. How many of them have actually been able to or have the experience giving oxytocin for hemorrhage in the past 3 months? Extremely rare, versus in hospitals, that's a common thing. So there are major deficits that happen from lack of competent staff, lack of experience and exposure to these cases. And so to summarize, when I talk to non-specialists about this, and that's not you, so apologies already for the simplicity of this point, but delivering primary care is problematic for 4 reasons. The first is that complications arise without warning. We don't have yet the technology. We know some people are going to be higher risk, and yet many, many deaths and morbidity happens among women at low risk. It's in every country. When complications do arise, they are difficult to manage and they require advanced skills, which we have learned, for example, in the Better Birth trial, many of those providers just don't have. Next is that so often the response to all of this is, well, we just refer those women. She'll start bleeding or she'll have a high blood pressure, we'll just refer her. Any of us who work every day and in many countries, and this isn't just the lowest income countries, everywhere we work, the idea that we refer a bleeding woman, a seizing woman, over rough roads for an hour or 2-hour trip is a figment of our imagination. That is not a path to survival. It works very rarely. Just as an example, in the Better Birth trial, fewer than 2% of cases were referred in those situations with a very high maternal and newborn mortality. And then last is this point about C-section. Cesarean section is simply just not available. There isn't advanced care. Of course, transfusion is also not available in these primary care facilities. So we are in a situation where the system response to these problems is not adequate. Where women are being asked to deliver is not appropriate. And so I just want to share with you, I've already shared the Better Birth trial, but I also want to share with you a study that Godfrey and I led together in Tanzania. The MNH Plus study, where for 5 years, this is a cluster randomized experiment that we ran and NIH funded. We did state-of-the-art quality improvement that we knew of, and it was really borrowing from the model of the HIV program. It was doing in-service training, supportive supervision by an extremely talented clinician, infrastructure improvement, even peer outreach to encourage women to come forward. And here's what we found on quality after 5 years. Basically no change in any of the items that we measured. And when we saw knowledge increases among providers because of these short-term trainings, those dissipated within 6 months. So this is really essentially null findings, and one of my mentees is actually going to be publishing these data very soon. So let's just look at what wealthy countries do. You know, it seems that we have pursued a somewhat different path, which is really regionalizing care, concentrating deliveries in facilities that do them frequently, that have advanced services. The slide here that you're seeing is the proportion of births in these 3 high-income countries that happen in small facilities that do fewer than 500 deliveries. And, you know, even in small facilities that are permitted to conduct deliveries, very often they either have C-section on site or extremely nearby access to C-section. So this probably even underestimates or perhaps overestimates the proportion of women who deliver in this kind of primary care level. So now let's see what happens in the countries with the highest mortality. And that's this, which is 1 in 3 babies born in a facility is born in a primary care facility that we are arguing cannot respond when an emergency arises. And so the first question I hope you're asking is, how feasible is this? This is a pipe dream that you're talking about. How can we get all these women in countries with poor infrastructure to hospital? Well, that's a great question, and it's definitely, there's not a ready answer. This is a multi-stage process. So the first thing we did is we worked with some of the commission countries that are our partners in this to analyze access today and access under a scenario that would have hospitals only do deliveries. And so you can see on the left and on the right 2-hour access percentages in the current scenario in Malawi and in a future scenario in Malawi. Today's within 2-hour access is 95%. Women have access within 2 hours. In the new scenario, it would be 94.7%. Now, this doesn't mean women on average don't have to travel further. Of course they do. And so this isn't a complete answer. It's just to say that actually in many countries, very few women are completely out of reach of a hospital. I also just want to draw your attention to the quality points there. That's just using that 12-point index, saying that overnight we would go from very basic performance of 0.62 to much better, still not perfect, of 0.8 on that index. And so how do you begin to implement something this big? Well, as I said, it is definitely a process. And it's a process that can only be led by people in the country who are willing to depart from the current status quo. And it's going to take at least 5 elements that we've been able to identify. And I say this slide really comes from our discussions with the government of Tanzania, which is considering moving in this direction, at least in a couple of regions, so we can see how this thing could work. So what do you need to do if you were to move to a redesign that focuses on outcomes and not on access? Well, first and foremost, let's improve the hospitals. Let's make sure that hospitals can handle the deliveries. Upgrading existing facilities would be the first step. Adding new facilities where needed would be a second step, depending on the expected delivery volumes. What we don't want is overcrowding and healthcare-associated infections to rise as a result of this. I think it's also going to be critical that that the quality of the staff and the care in those hospitals is of sufficient level, and that's going to require hiring of more staff. The good news is that there are fewer places to hire for. If not every facility is providing obstetric services, it means you don't have to hire 1,000 midwives. Instead, they could work on midwife teams in these facilities, in a normal delivery unit or a birth center next door to a hospital capable of C-section. So thinking about efficiencies as well and health worker shortages. Second, you would have to boost primary care, because right now there's very little continuity between the primary care clinic, which should be doing antenatal care and postnatal care, and the hospital. And so that's going to need work. A big one, of course, is enabling people to have access. Again, I will just remind us what's the alternative. The alternative right now is that we are transporting women who are extremely sick when they develop complications with a system that is very dysfunctional. This strategy would say a proportion of women need support to get to the right level of care. How can we do that? What are the intersectoral implications? I will tell you that our colleagues at the World Bank are very keen on this and are working with transportation colleagues to say, let's strategically improve roads and think about transportation networks to reduce maternal mortality. But we'd also need vouchers, public-private partnerships, and other modalities. And of course, a huge piece is building demand and educating communities, working with women, working with community leaders to move in this direction. I think that last one may not be as hard as we sometimes think it is. And that's because of data that we have and many have seen and themselves experienced, that women already, many of them prefer to deliver in hospitals. We see substantial rates of bypassing of primary care facilities when people vote with their feet to avoid care they don't want to be getting. And of course, this is going to require policy change about what can primary care clinics do, what do hospitals do. And so some considerations for redesign, and these are the last few slides I will leave you with, are really around what's the right range of MCH services offered at the primary care level, what new services need to be introduced in terms of much closer monitoring of the newborn, for example. How do we do coordination? What are the minimum requirements for those secondary care facilities? Can they be health centers with operating rooms? Do they need to be hospitals? What do we need? And how do we sustain quality in those clinics as well, in those hospitals? And then I think we do need to think about equity very much, and so that poor women are not the ones, again, left furthest away, furthest behind, because we know they will be in potentially more remote areas. So we need to think about them first. And I would suggest that when we're doing all these improvements, that we target the most remote groups first and think about how to get them to the right level of care. And of course, we do have questions around the evaluation. How do we know this works in low-income settings? I think many countries have moved in this direction, but we don't necessarily have evaluation for low-income countries. So that's really my last slide. I'm just going to leave you on the one point that I hope you're also thinking about, as we have been thinking about, which is what are the dangers in such a move? Beyond leaving women out in terms of access, there are also real questions to be asked about over-medicalizing birth. And we've seen a huge transition in many middle-income countries in particular. I'm thinking about Mexico, I'm thinking about China, not to mention, of course, Brazil and others, where a move toward hospital delivery has been accompanied by a skyrocketing rate of C-sections. And we really need to all put our heads together to figure out how not to let that happen as low-income countries and others, we hope, transition to a much more effective health system for their mothers and newborns. I don't think it's a necessary thing to happen. I think if we think about delivery carefully and think about triage and I think critically involve our midwifery colleagues in this effort, so this isn't purely seen as an obstetric intervention effort, but really an effort to maximize the potential of health systems for women, then we will come up with a model that is both a life-saving model, but also a model that respects women, allows them to have a birth of their choice in a low-risk setting, and I think hopefully also benefits providers in being able to work in a team that supports high standards and high quality. So let me stop here. I'm really looking forward to the discussion.
Thank you very much, Margot. That was an excellent presentation and really good. Thank you. Yeah. a great overview of the recommendations. So I'd like to move on, if we may, to begin the discussion. I know Margaret will stay online, so don't worry. When we come to the questions, she will be available to answer questions. So I'd like to turn to my left here to Michelle Pino. As I said, she is a healthcare provider in the Indian Health Service and working with women in the Navajo community. So you will be looking at the women's experience. So to you.
So thank you for giving me the opportunity to join you, give you a different perspective. I work with Indian Health Service at a small rural community hospital about an hour west of Albuquerque. And it is, it serves 3 different tribes in the area, and our service area probably encompasses about 125-mile radius. And I'm just going to give a little different perspective, because the goal of Indian Health Service is to provide care for women in the community which they live. The goal has always been to provide that high quality care within the community and allow women to stay, both women and their families, to stay in the community and receive that care. So there's been creative ways that Indian Health Service has been trying to meet the demands. Some of the stuff that they had talked about is some of the initiatives that IHS is actually working towards. And as mentioned earlier, medicalizing birth is just an example. And that may not always be the answer of having women deliver in the high medicalized birth facilities. Indian Health Service has a very low C-section rate. And I don't want to quote the lowest rate, but it's lower than the national average, which is very important because the initiatives that they are working on the delivery rate and the C-section rate speak to that. So it's one of those plugs that we have for Indian Health Service, that although we do provide rural health care, the majority of the health centers are on rural reservations, and we do care for high-risk populations. Our outcomes are very good. So there are ways that we're trying to bridge that gap. The first way is bringing, instead of taking the providers out of the community, to provide training and education, because a lot of people who practice in small rural hospitals, it is hard to leave their practice for an extended amount of time to get care. The care and education is brought to the providers. One of the models that we are working with within Indian Health Service is called Project ECHO. The Extension for Community Healthcare Outcomes was actually developed at the University of New Mexico, because the state of New Mexico is so broad and wide, and there are a lot of rural facilities that the physician at the University of New Mexico decided to come up with a way of how can we educate providers to remain in the communities and have the patients remain in the communities and provide quality care. So you can think of it as a hub and spokes model, the hub being the university center, the academic center, and out of that branches out the small rural communities. So what happens with that is not only are you getting the expertise from the academic center to the providers are also building that relationship with other rural healthcare facilities. The principle was built on there's never going to be enough specialized providers to deliver all the healthcare that's necessary. And how are we going to cover such a broad area in a short amount of time? So again, it's built up to create mini specialists at the individual sites. And the way it's done is through the use of technology. Pretty low-tech technology. You can access the hub, the academic center, through 3G phones. You can access it through with a very basic smartphone. So that's how the information is disseminated to the local rural facilities. And then also they're looking at best practice. They're always continuously evaluating their methods of teaching. They're looking at best practice, how it's disseminated through the use of algorithms, the use of checklists. So again, this helps rural facilities that may not have that high volume, may not have that high exposure, to standardize care, to look at, okay, how am I going to follow? If this person presents with this, this is what we're going to do. This is what the algorithms say. And so that way care is standardized. The other thing, it's based on case-based learning, which is used a lot during residency. Not only are providers learning from the academic center, individual cases which may be pertinent to the community are shared with the providers at the rural sites. So again, it provides an opportunity of two-way learning. And then the most important piece is monitoring outcomes. As we heard earlier, it's always important to follow up through quality review. What we're doing, is it working or not? So that's an important piece of having people learn two-way learning, I mean, from the academic center to the rural facilities. The other thing that we, within Indian Health Service, they are doing is looking at how care is delivered. Not only are we looking at qualified healthcare professionals, but we're also looking at the system in which the care is given to the community. And right now there's an initiative to have the IHS facilities use the patient-centered medical home as a model, because this is very important. The patient is at the center of the care. They are very part of developing goals. They're part of their healthcare decisions. They're brought into the process along with the healthcare team. The healthcare team consists of a healthcare provider. It may have nurses, pharmacists on that team. So the patient is able to build a relationship with their healthcare team. The providers may come and go, but the continuity is going to be within that healthcare team, which is really important because that also builds trust for the women to return for their care. And trust is a huge part of having people access the healthcare system. So IHS, again, because it's the whole goal is to provide care in a culturally acceptable manner, that women feel comfortable coming to their healthcare team to receive that care. And then also what IHS is doing at the individual facilities is developing ways to continuously train providers. They work in conjunction. They pair low volume facilities with high volume facilities and train not only new staff coming on, but also provide continuous education for existing staff there. So again, it's a way of continuously developing staff. And let's see what the biggest impact. So switch sides. And we all know that impacts on the women and their families is very important. So again, what we're trying to do is keep care in the community. And if you have a healthy community, you're going to have healthier outcomes for the entire community. Impact on future health is also important because we always believe that if you get the woman who is in charge of healthcare, they're going to bring their family, they're going to bring their kids. And if we take away that opportunity for them to receive care, it's going to decrease the opportunity for that entire family and community to be healthy. And so these are just ways that Indian Health Service is looking at improving the care that they deliver within their rural community.
Thank you very much. Thanks for that, Michelle. A couple of really important points that come to mind when I hear that is the trust, and I think we'll talk about that a little bit more, and that the services are designed with the patient in the middle, which is excellent. So on that, going from the individual and the contextual design for the individual within context here in the US, I'd like to move over to Osman, who will talk to us a little bit more about communities and the health system and how we may move further towards Margaret's goals.
Thank you very much. I will be talking about how governance and leadership will help with planning, but carefully planning to make it happen and make this recommendation maybe implementable. We all know that the health system as Margaret mentioned, in DRC, where I'm from, is very fragile. And yeah, you saw her figure. DRC was the first country with the highest maternal mortality, but also the highest coverage rate for maternal delivery. And in that area, our work is to help countries, governments, to carefully plan based on evidence. In the case of DRC, they made 5-year plan. And one of the priorities was to build hospitals. But since they didn't have enough means and there were gaps, they decided to upgrade health centers to take the burden needed to address the needs for specialized care. This was done with all partners supporting this. It was a joint planning, but at the implementation, what we've seen was that we were not able to achieve what was planned. Why? Because lack of resources. The government made available domestic resources, the partners as well, but was not able to achieve that. But in the second plan, which is still being implemented, the government changed the priority based on evidence to focus on strategic purchasing to improve quality of services. Why? Because in that system, for example, providers are low or not paid. In that kind of settings, it's important to make sure that the government and all stakeholders understand what it takes, what is the current situation, analyze it well, but what it takes to make the shift, and based on evidence, and then prioritize carefully. But one critical point to add is that the political stability is critical. We know that in DRC, political stability has been one of the major problems, and it's still ongoing. And the plan I was talking about, for example, is that when they shifted government, they repealed what was planned. It is one of the critical, and it's not specific to DRC, but even somewhere else we are repealing things that are good. The next thing is that we talked about the community and the social accountability. And in that area, we know that it's an opportunity to having health facility governance committees available in supporting the system. They are working, but the issue here is that they are not quite independent. They are dependent to the health facilities, so they are more likely to be supporting the health facility and not supporting the community, to improving the access. That's a reality. And in DRC, we're having the same issue. What we've done with all partners supporting the Ministry of Health is mobilizing the resources that are available with grassroots organization so that they can improve the health facilities, sometimes buying equipment because government is not doing it, and supporting also transportation of clients and women who are delivering to reach referral health centers or hospitals. The last one is about the role of community in ensuring equity. This is also very critical, and we need to think about what it will take if all deliveries move to hospitals or other centralized health facilities. How do we prevent this from becoming another source of inequity? And I don't have the answer, but we can debate on it. But it's very critical. What we've done in DRC was to help through the champion communities, where we have champion woman, champion mama, champion men, and also champion youth, to helping to understand what needed, to take the burden from the woman, the household, and have the community own the burden. That's how the champion communities helped, for example, to negotiate reducing the fee for services, but also paying for transportation of women that are referred to hospitals and referral health centers. And this has been very successful, and we think that whatever we should be coming with, we need to make sure that the community as a group is strong enough to find solutions that are really their solutions in their communities in order to help improve the status of women and babies. I will finish saying that this is a journey to heaven for us as a community. And the journey to heaven starts with saving lives of women and babies for our community. So we face many challenges. We'll continue to face challenges, but we're here for challenges. We learn from what worked, what didn't work, and we plan based on evidence to continue saving lives of women and babies.
Thank you so much, Usman. It's really a very passionate, passionate review of the work that's been done. And you know, two, three words come up in my mind: political will, priority setting, good governance, good resource mobilization and utilization, and really then social accountability. And particularly I'd like to bring out that point that you made around, you know, many of the community structures in the past have been looking at how can they support the health centre rather than how can they support the community in which they're operating. So I think that's a really good point. So Barbara, to you.
Well, great. That was that's a hard act to follow. But I wanted to talk a little bit about how we have thought about the culture of safety and quality. So quality and safety are not exactly the same thing, but when we're talking about quality, we're often talking about maternal safety. And we've been facing this issue in the US quite a bit. There's been a lot of conversation about the maternal morbidity and mortality rate in the US. And ACOG has been working for the last 4 or 5 years on a program of maternal safety to try to improve outcomes. And what I want to share with you today is our little experiment to see whether we could adapt that same program to an ultra low resource setting in Malawi. And so here's what happens in California with the adoption of patient safety bundles. Bundles are sets of activities that are fairly straightforward and simple, but that can transform care in a way that's consistent. And California was able to see a reduction in maternal mortality of 50% by doing these relatively straightforward, simple things. This is not that people don't know what to do. It is that they don't know how to do it. It is the systems that we've all been talking about that's so important. So what we did was take a look at a place that has an ultra high maternal mortality rate and an area where the maternal mortality was specifically related to obstetric hemorrhage, because that's something that is remediable. It's something that we could wrap our arms around, and we already had a safety bundle related to hemorrhage. We knew it worked in California. Could we make it work in Malawi? And we partnered with Baylor College of Medicine that already had a professor and some global scholars, some people there full time who could help us implement it. And we started by querying the staff, both at an area health center and the tertiary hospital, to see what was the culture of safety like before we started. What did they think about teamwork? What did they think about what was going on? And then once we've done our intervention, what happened over 6 months and 12 months? And now we're actually closer to 18 months out, and we have seen a sustainable improvement in a culture and a sense of teamwork and safety in this environment. And most importantly, we've seen a huge reduction in maternal mortality. We have seen an 82% reduction in maternal mortality related to hemorrhage. Well, how did all of that happen? It's about teamwork. It was about training folks, very similar to the ECHO program in a way, was training the folks from the area health center and the tertiary center together so that they became a cohesive team. It wasn't the health center out here referring people into the tertiary center. It was everyone taking responsibility for that patient. And it's a set of activities that we have come to, we call them the 4 R's, but it's anticipating what might happen. So it's being ready. And that was doing a risk assessment for women when they came into the health center. Are they at risk for hemorrhage? And if they are, do we have oxytocin? Or did we lose power and we don't have it, and therefore we need to transport this patient now before she hemorrhages? We taught them to be ready, to recognize a hemorrhage. So we taught them about the stages of hemorrhage. We told them how to respond. So it's readiness, recognition, response. We told them how to do balloon tamponade, how to have IVs in place, how to manage the 3rd stage of labor, and then very most importantly, reporting. At the end, what happened? And how could we do it better next time? And what the Malawian nurse midwives taught us was that they were far better at reporting than we are in the US, and they figured out a system. And their system was they could not relock the hemorrhage cart until they had the report done. And so they created a system for themselves that said, we are going to make sure we debrief every single situation to be sure that we are where we need to be. And so just to show you the impact, it's very similar to what we're seeing here in the US, with about a 20% reduction in severe maternal morbidity with implementation of these kinds of safety activities. And that we were in Area 25, which is a rural health center, we were able to get very similar decreases in severe maternal morbidity. Again, it's the systems. We've been talking about it all afternoon, but it is really about ownership and trust and teamwork. It is about, the people feel so much better when they're part of a team and everyone's pulling in the same direction. And what happens in health systems, we get so busy and we get so stressed that we all end up working against each other in ways that don't make any sense at all. But because we don't have relationships, and I think that's such a key, and Michelle, you talked about it, but the relationships between the outlying places and the tertiary care center, if you know the people and you talk to them and they know you trust each other, and good things happen. There are the obstructions to transport and all those things don't happen. So I think relationships are just absolutely critical. So quality is a big thing. We can have measures and all kinds of process measures and outcomes measures, and we need to have those things. But in the end, it's about relationships, it's about trust, it's about creating a structure that really works.
Great, thanks so much. So we've heard from our 4 speakers now, and I hope that we're going to get her back online so we can see her. We do have a reduced time for questions, because I would like to give the floor to Mary Ellen for 10 minutes probably at the end of our question time. So those of you who'd like to ask questions, give comments, would you like to go up to the podium just over there with the nice microphone? If you could just form an orderly queue, as we would in the UK, because we're very good at queuing. So any other, well, we have our first question, and hopefully it will encourage others to come along. So if you could just say who you are, where you're from. If you have comment, can you make it just one? Yeah, brief comment, but then questions, and just say who you may like to ask. Oh, hang on a minute. You have to turn it on, sorry. Last instruction, I forgot.
My name is Embry Howell. I work at the Urban Institute in Washington, D.C. I did have a comment, so thank you for letting me make it. I'm so glad to see ACOG recognizing the important role of midwives, and I hope that continues, especially in the United States as well as abroad. My question is, have any of you, so I don't know who to direct the question to, but considered pay for performance, providing financial incentives to providers? And if there are experiments like that going on, could you tell us about those?
Okay, so should I give it to Usman first? Because I know that you have had some on-the-ground experience with this. And then maybe the other panelists would might like to chime in. Yes, because I don't see a big queue at the podium. So
Okay, yeah, thank you very much. Yeah, in DRC, we supported the government in piloting results-based financing, because as I mentioned, DRC is a special country where providers are not paid. So motivation is an issue when it comes to delivering good quality of services. And the government has decided to making it a national program. And that national program is actually focusing primarily on maternal, newborn, and child health. And that's what I mentioned. I referred by strategic purchasing. So it's RBF, results-based financing, but primarily targeting maternal, newborn, and child health. And the government is funding that in Kinshasa and other partners like USAID and the GFF platform are supporting the government in other provinces. And the goal is to making a nationwide program to help improve the quality of services, but because that's the focus. The quality of services should be improved through that mechanism.
great, thanks. I don't know, Margaret, if you have a comment on that, if there's anything that you would like to say around that from your research.
Just very briefly, that performance-based financing is one of the modalities we examine in the Commission for quality improvement, and it's been applied extensively by the World Bank and others. And while it definitely does raise utilization, the quality improvement is less impressive and is often confined to tasks that were cognitively easy to do. So when we look at the overall investment required in that effort, we are not persuaded that that is a system-changing strategy for quality. I think it does other things. We can argue about whether those are good or bad. Giving some autonomy, for example, financial autonomy to facilities may be a good idea. But in terms of its impacts on quality, those findings are not encouraging.
Okay, thanks very much. I'm going to go to another question now, because we do have an orderly queue, which is very nice.
Hi, Winnie Mwebesase. I am the Senior Director for Maternal and Reproductive Health at Save the Children. Thanks for the panel and the presentation. I wanted to maybe ask a question, and this is related to Margaret's presentation. There wasn't, and this is asking about human resources for health. I didn't see that featured in her presentation as one of the aspects that needed to be addressed. We work in several countries. When you look at where the human resources are deployed, they are mainly deployed in large capital cities. And so even if you're thinking about equity and having a strategic distribution of your facilities so they cover the whole country, if 70%, if 3/4 of all your human resources for health are in the capital city, and there are no incentives to deploy them out and to keep them there because their families need to go to school and there are no good schools. And so if we don't address that, you can build roads, you can build bridges, but if you can't get people in places where they can bring their families up in good conditions that are equal to the capital cities, you're not going to retain them. So I would want to argue that we need to look at human resources for health deployment so that we can achieve equity and ensuring that there are incentives that are going to keep skilled providers out there in the same facilities, but out there where they're needed.
Thanks very much. Actually, I'm going to turn to Michelle because that was one of the first comments that you made, wasn't it? Was that that's not just an issue in Tanzania or DRC, but here in the US too.
So with Indian Health Service, that is a huge issue. And I'm glad you brought it up because we are looking at ways of retaining or recruiting qualified professionals because healthcare is tied economically to the community. A healthy community is going to be a financially sound community. Right now, Indian Health Service, in order to recruit people in, there's a financially, they can request for loan repayment, which brings qualified professionals into the community. It's for X number of years. Usually the obligation is for 2 years, but that brings people into the community where they're going to be serving. And then can you, the second part of the question, I should have wrote it down. What was the comment that you made about bringing the services in? You remember? Okay,
Yeah,
yes.
it was retention.
So it
retention
was.
of
So
health workers.
again, it's that piece that building that relationship with the community. If healthcare professionals feel like they have a tie to the community, not only the patient feels that relationship with them, but the providers also get something from it. So again, it's a two-way street on that. And it really helps with the retention.
Thank you. I don't know, any of our other panelists want to make a point on this?
Just that training people in their own communities is critically important. And so part of Indian Health Service activities is trying to recruit high school students as nurses and then helping to pay for them to go to nursing school and bringing them back to their own home communities so that we're recruiting people in their villages, in their homes, in their places to do work.
Okay, thank you. And I know there are many other schemes, but it's a long conversation. So we'll go to the next question.
Hi, I'm Charlotte Warren from Population Council. I'm a senior associate, mainly focusing on maternal and newborn health. Thanks everyone for all the very interesting discussion and comment and presentations. I would just like to make a couple of comments around the teamwork. We found the same issue where people work in teams. Things are much better where the providers have autonomy. They're much more likely to provide the services that women and their newborns need and want. But is this? I think it touches on the previous question around retention, because you may have a great team and then somebody leaves and then things dwindle down. So how can going forward, how can we maintain that teamwork? And surely we should have the community involved in that team as well to be making sure and holding people accountable. I don't think there's been quite enough discussion on the community holding the health service and the government accountable, and that would be a piece that should go forward.
So again, I'll just speak to that. using the patient-centered medical home uses the team approach, and the studies show that there is provider satisfaction along with increased patient satisfaction. But again, because providers may come and go, the stability is going to be within the team. And a lot, exactly what you said, the team of nurses, the team of other healthcare, that healthcare piece, those people are coming from the community. So a lot of times I tell people when I'm recruiting providers out there, patients come to see the health techs and the nurses just as much as they come to see the healthcare provider, because those people are from their community. They're going to be stable. They're going to be the ones that stay. The providers may come and go, but that stability within the team approach is going to depend on every member of the team.
Great. Margaret, did you want to comment? It's hard to see whether you wanted to comment on that.
Sure. I think that both this question and comment and the previous one and hi Charlotte are very much the topics of our analysis as well. There's no question that humans, competent, caring humans, are at the heart of this equation and are completely critical for survival. I think that shortages are a problem, and one of the things that concentrating services, particularly again for delivery care, in larger settings, is it permits teams to form. So one of the things that we noted, for example, in the Better Birth trials, there's 3 or 4 providers, period, and they're dealing with the whole facility. Very often. So this actually is a way to try to encourage retention, encourage teamwork and collaboration, also critically using the skills of midwives and doctors in an efficient way in low resource settings. And so I think that's good for efficiency. It's also good for retention. But having said that, I also hear the point about doctors being reluctant to go to rural settings. Again, I think they will be less reluctant when they're in districts, which are usually small towns at least, and not very remote settings. And I think one overall comment that I would make, because I really appreciated the comments of Michelle about the Indian Health Service, and it really reminded me of my first job, long before I did research, which was running a hospital in northern Canada and doing deliveries in a center which did not provide C-section. And I think we had many of the same concerns. And I think one really important point to make when we look at the recommendations and the approaches that Michelle is suggesting and that we are discussing here, that we propose in the Commission, is these are vastly different worlds that we are talking about. A world in which any obstetric care provider will have a solid core skill set, including experience in delivery, is not the world that we see in low-income settings and primary care clinics. A world in which when a woman begins to, lag on her protograph, we can call for a helicopter to transport her to a C-section, waiting, C-section within half an hour, as we were able to do in Northern Canada, is not the world that we see in sub-Saharan Africa or in India. And so I think one important point to just raise here in this discussion among the experts in the room is that setting and context really, really matters. And while I think it's very commendable to want to keep women near communities and near their loved ones, and I think, the issues of how do we make sure there are companions in birth and that women are able to be surrounded by people that they care about and love, those are critical issues. But so is their survival, fundamentally. And right now, the kinds of setting that I had the privilege of working in Northern Canada, although very much resource constrained by Canadian standards, is not a setting that I have ever seen in rural India or rural Africa. That is simply just not possible. So I think it's important to maintain, as we continue this discussion, these are not opposites, right? There's a continuum of circumstances, of needs, and of mortality levels that are going to require us to think about the core issues. And the core issue is the care competent and able to save a life, number one? Is it able to give women and newborns a respectful experience? Right? And is it using resources in the best possible way, responsive to communities and responsive to other priorities? And again, the answer to meeting those principles is going to look different in different settings.
Great, thanks very much. We have 2 questions, I think, we're going over time. So we will have 2 quick questions and then we'll go to Mary Ellen. So Indira.
I'm Indira Narayanan. I'm an adjunct professor in Georgetown University and an independent consultant in maternal and newborn health. I'd like to congratulate all of you. It was an extremely interesting panel and very thought-provoking. I'm so glad that you addressed the quality of care and teamwork, which are so important, and addressed the health systems. But I wonder if we have really addressed or even begun to address one of the other questions that you have posed, is whether deliveries can take place in all facilities or they need to get into specific facilities or hospitals. That is, of course, a far more difficult question to answer and discuss. But I wonder if we could consider, and these thoughts just occurred to me as I was sitting here. I have no proof for whether they're going to work or not. One is an evidence-based risk assessment, which should take place in the antenatal clinics. And although problems can occur in a woman at any time, we can't always predict them, but there are a set that you can sort of identify and decide ahead. And we need to do more motivation that mother should go to a particular hospital. Related with this, we have sort of recommended in some of our programs mapping of the facilities and what services are available in the various facilities, which should be known at all levels. Because if the referring person does not know where they should send a patient, they go multiple places, and especially from the baby's point of view, they die before they even reach the place. And then the other crazy idea which just occurred to me when I was sitting here is that suppose we want to refer these women to a hospital which is very far. They can't go at the last minute to that place. Is there a place for a maternity waiting home in that particular area near the bigger hospitals or the referral hospital where you want a problem mother to go? I have no proof or anything for this, but these thoughts just occurred to me when I was sitting here. Thank you.
Thanks very much, Indira. Unfortunately, we don't have a lot of time now. We have two quick questions, I think.
I am just going to take a few questions from online.
Oh, yes.
Just to make sure we give those, the online folks a chance to ask questions. So the first one is, great talk, everyone. Thank you. Completely agree on the point of including midwives. Can you expand on how that will improve quality and respectfulness in care around birth and let women have the birth of their choice? And then I'll just ask one more question from online from Juan Carlos Alegre, who says, can you tell us how much it would cost to implement the quality-centered redesign in those priority countries that have had the most burden of maternal mortality due to birth complications?
Yeah, great, thanks. So the first one, the first one around midwives, and then the cost. So, who would like to take the midwives?
I can speak to the midwifery model a little bit. The midwifery model looks at taking care of the woman as a whole. It looks at birth as a normal process until proven otherwise, and really doing a good job at risking out and doing that early assessment of who is appropriate for care at that particular facility. So a lot of times, again, medicalizing birth is not the answer. It's treating the woman as a whole and giving them that opportunity to have a voice in their care.
Thank you. So, Margaret, have you done the costing exercise for this particular?
No, that's a pretty large undertaking, and I think it's a great question. It's a really important question. I think one thing to keep in mind is that the current status quo has large costs. Every clinic needs to be equipped with providers and equipment and so on. So I think it's always useful to remember that when we're asked to do hard things, that the things that we're doing today are also difficult and not yielding the results that we want. But absolutely, this does need to be costed and does need to be thoroughly evaluated in countries.
Great, thanks very much. I know we've got a lot more questions we'd like to ask, but I'd like to give the floor to Mary Ellen Stanton at this point to give us a few reflections on today's proceedings.
Good afternoon, everyone. This has been a fascinating afternoon, and I'm so grateful for all of the presentations that have provoked us to think hard. And I think putting out this whole idea of moving women to hospitals where they can get the life-saving care, why don't we do it, raises so many questions for us. And I'm thankful for Margaret for putting out a case for that. I think in terms of reflecting on all of the input that came in, I would like to go to some of the panelists before going back to some things that Margaret said, because what I heard that is essential from all of you is the importance of team, of building relationships, of having care really be centered on the woman, building in social accountability to the community and to the families and to the mothers themselves. And that in the work environment, the whole cast of characters who are providers need to work synchronously and in different ways. Absolutely, all of you said that, and that some of you provided good support for bringing down mortality and tackling some of what Margaret termed residual mortality. So I think there's a lot of room for discussion here on how in these very different environments we're going to reduce the mortality and the morbidity, and to the best extent possible allow for normal birth to take place and not mess with the normal processes, not create over-medicalization, which in itself is costly and not so good, but could inadvertently cause iatrogenic problems, mortality, fistula. Imagine having a fistula in the hospital, think it's going to prevent it, and you have your C-section and something like this happen. So in going back to one of the slides that Margaret put out, I think early on in her presentation, she talked about deliveries in primary health care centers. And I think she had 4 points that were problematic. And although she discussed some of this later on in her presentation, she didn't have, following that slide, if I may say, Margaret, how deliveries in hospitals can be problematic. Because I think from that point of view, there are so many pluses and minuses. I will say for myself, I lean toward, and often have, toward what Margaret is suggesting in this careful analysis from the commission, that people would have a better chance of survival if they were close to the highest quality care that could do the sophisticated care if needed. I think we have learned that although we hoped a risk approach would work, we have found that, as has been stated, these complications are sometimes could sneak up and surprise us. And the low-risk mother has the terrible birth experience with many, many problems to be addressed in the most sophisticated way. I think that it's very easy to think that we can get the data, like better outcomes, better survival. But if we don't have the real appreciation that birth isn't just a medical event. It isn't just a procedure. And I know everybody here really believes that, that to be able to maintain birth as a significant life event, with all of its cultural and spiritual possibilities for the mother and the family, that we can hope to attain that along with survival. And I just wanted to close because I know this is coming to the end of the time. But in reflecting back on what Catherine said at the beginning, that brought us all to be thinking about the 17th anniversary of 9/11, and not only what happened to the victims who died, those who survived and their families, but that the frontline actors, the firemen and the medical people and everyone were so important. And that's true in birth, in the hospital. Also, the unexpected tragedy of things turning badly, as they did for our dear colleague, Dr. Mbaruku, and mothers in our care, is we think everything, we know what's going to happen, and then all of a sudden we're profoundly affected by terrible loss. And so that being better prepared to do the best we can is what I know we're all about. Finally, I wanted to say there is this concept of reducing the residual mortality. And in reflecting back on how we did in the MDGs, we like to spin it, we reduced it 43%. We reduced it only 43%. That means that we didn't even get halfway in the global burden. And of course, we'll all be looking for the next global estimates of maternal mortality to come out by early next year, if not late this year. But we're seeing from our demographic and health data that it's quite variable how countries are doing. And the countries with the high burden, some of them are continuing to make advances, some are plateauing or stalling. And they aren't stalling for the last couple mothers. There are still thousands in the countries of preventable deaths. And the thinking hard at the kind of things that Margaret brings up of how do you change health systems and how do you reinforce the best kind of quality practices, be they small hospitals, be they through enlivening really effective transport and referral systems, so that we take advantage in the different environments as we try to get the funding to do this massive effort and do it in the very best way to preserve the character of birth and the safety and health of the mothers and the babies. Thank you.
Thank you very much. So that brings us to the end of our time together. I would really like to thank all our panelists for a great presentation, a lot of thought-provoking questions that we all have to consider. And really around the thing that comes to me as just one last comment is that we really need to establish very human-centered health systems that meet the needs of the people that we are trying to support. So just on that note, I'd like to thank you all again, and particularly Mary Ellen for closing the session. Lots more questions, lots of discussion. So please do go outside to our reception area where we can keep on that conversation. And if you want to go to the museum, I'm sure ACOG will be very pleased to show you around. And I would like to again thank all of our support. Amazing that we're able to beam in Margaret so nicely from Boston. It's quite a feat, and I know quite a bit of planning went into it, but it really worked very well. So thank you very much.